exclusive learning management system for you, where module and courses are designed for young oncologists looking at the need of next-generation cancer sciences, so that we build the capacity of oncologists for next decades. The IAIO Academic Council comprises a diverse group of subject matter experts from various oncology disciplines to deliver education through online classes in affordable prices with opportunities of academic grants. At IAIO, we believe every step of your clinical practice could lead to a new innovation in cancer care. We partner with clinicians in every step, for enhancing their practice information and patient data to novel research by transferring your treatment's methodologies into scholarly publication. Our global network brings researchers of similar interest for collaborative research and drive ongoing studies and decentralized clinical trials. IAIO Library and Resources offers a vast collection of scholarly materials to keep you updated with latest insights on best practice methodologies. We understand upscaling your knowledge is the need of humanity. Let's give a healing touch to the life of cancer patients and survivors through initiatives of IAIO Humanity. Our patient and public welfare initiatives are driven by IAIO Community. Our communities and networks bring together experts from across the globe, fostering an environment of collaboration, shared knowledge, and ensures comprehensive support across all branches of cancer care. Join IAIO's exclusive membership with Abode of Opportunities, where we believe in a world where knowledge drives progress in oncology. Let's shape the future of cancer care together.
Welcome, Bala sir. Good evening, sir. Good evening, Sika.
Haldar.
Shall we start? Hello? Hello?
Yeah, yes, sir.
Shall we start?
Yes, sir. Yes, sir. So, good evening, everyone. A very warm welcome to IAIO Expert Insight Lung Cancer. On behalf of the International Association for Integrated Oncology, I thank all our distinguished faculty and participants for joining us today. Today's session is to provide practical evidence-based insights into the evolving landscape of lung cancer management from early stage resectable disease to advanced metastatic settings. Before we begin, it's my honor to introduce our program director, Dr. Bala Stalin Chaudhary, Chief Medical Oncologist, Hemato-Oncologist, and BMT physician, Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam, Andhra Pradesh. Sir, thank you for leading this academic initiative. May I request to deliver the opening remarks and please, we now move to our first talk. It's my pleasure to invite Dr. Bala Stalin Chaudhary. Over to you, sir.
Okay. Uh, Thank you. Thank you, International Association of Integrated Oncology, for this opportunity. So we all know that this association of integrated oncology, the International Association of Integrated Oncology, is taking a lot of strain for the academic thing, and this is a purely a non-sponsored program conducted purely for academic purposes to learn the insights of various malignancies. And today the malignancy of discussion is the lung cancer. So we all should acknowledge this IAO society, especially for such a great initiative of continuing the academic program. Okay. Today the topic of discussion is the lung cancer. So among them we have three talks. So the first two sessions will be on localized lung cancer, so in the adjuvant and neoadjuvant setting, and rest all two talks and one panel discussion will be on the metastatic setting. Unfortunately, Dr. Rajni Priya is unavailable due to some family emergency, so I will be delivering the talk. So there is a slightly altered flow of thing according to the schedule. So first, Dr. Rachna will be taking the session. After that, I will be taking the session of Dr. Rajni's, then two panel discussions, and the final one more talk. This is the flow of presentation today. Without much waste of time, we will start the session. So because we have a 5 sessions to be scheduled to be completed within time. So without much waste of time, I would like to introduce Dr. Rachna Channamaneni, who is a senior medical oncologist, associate professor in the Department of Medical Oncology at Nizam's Institute of Medical Sciences, Hyderabad. She had a vast experience of 8 years in the field of medical oncology, and I would like she will be talking on adjuvant therapy in resected non-small cell lung carcinoma, targeted therapy, and immunotherapy in 2026. Over to you, Rachna.
Thank you, Stalin sir. Thank you for this opportunity, and thank you, IAIO, for these wonderful sessions on different malignancies which are being conducted at a very frequent intervals and very beneficial for majority of the students and faculty as well. Without wasting time, I would like to share my screen for the presentation. Is the screen visible in the presenter mode?
Yes, ma'am.
Yes.
Yeah, okay. So I would be discussing about the adjuvant therapy and also a little bit on the perioperative therapy of management of resected NSCLC. So this would be my agenda for today, a brief touch upon how we manage the early stages, the stage 1 and stage 2 and stage 3 resectable tumors also. So these are the key 2026 updates I would be discussing a bit in detail about these trials, the ADAURA, the ALINA, Keynote, Checkmate and trials, and all based on the NCCN and ESMO guidelines. So before directly jumping into the adjuvant treatment, the staging is what is most important in the early stage lung cancer. Metastatic, once it is diagnosed, then our work is mainly based on the treatment. But for early stages, it is how properly we stage them helps us in deciding the treatment options and also to manage the patient properly and improve the survivals. So these are the commonly done non-invasive stagings, imagings, mostly the CT, chest or abdomen, or PET-CT, which is being done in most of the centers in India now. And also MRI or the CT brain becomes an important part of staging in the early lung cancers to identify the metastasis in the asymptomatic patients, which would upstage and also change the treatment management. And yes, invasive staging also becomes important in the early stages, more so in the early stages than the metastatic setting, We can either do the EBUS or mediastinoscopy or VATS or thoracoscopy also when we have to stage the mediastinum. So if we have a stage 1 NSCLC, the major treatment of stage 1 NSCLC is mostly surgery. And these are the different surgical options available. The most preferred one being the lobectomy, which is the historical gold standard, which also includes lymph node dissection. For some patients whom it might not be possible to do a lobectomy or the tumor is very small, where a segmentectomy can also be done. Wedge resection is a non-anatomical resection usually done for a very high-risk patient for surgical surgeries. And when a patient is not fit for any of these surgery, the other option we have is the SBRT or SABR. So there were some studies which have compared surgery versus SBRT or the conventional RT versus SBRT, and they have shown that surgery is preferred option. But for few patients, we can't do surgery. These are mainly the medically inoperable stage 1 NSCLCs, or the patient is refusing surgery, or the FE1 less than 40% of the predicted value, and a peripheral lesion which is small, less than or equal to 5 centimeters, elderly people, especially more than 80 years of age, or patients who are oxygen dependent because of various reasons. So these are some group of patients where a surgery will not be possible. For these patients, we have to plan for a SBRT. And moving on to the stage 2 NSCLC, and also the stage 2 and stage 3 resectable NSCLC, here comes the main concept of adjuvant therapy. So initial evidence which we have was of adjuvant chemotherapy. The two major studies which we have for the adjuvant chemotherapy, which is the basis for us to give an adjuvant chemotherapy, is the LACE meta-analysis. In this LACE meta-analysis, they have shown that with the addition of adjuvant chemotherapy to a resected lung cancer, the 5-year overall survival benefit is 5.4%. But if you observe the stage 1A, the hazard ratio is 1.40, which is showing that adding an adjuvant chemotherapy actually causes harm than giving a benefit. So yes, avoid adjuvant chemotherapy in stage 1A NSCLC. Stage 1B also, it is a very mild benefit, not a significant benefit, with a hazard ratio of 0.93. Whereas in stage 2 and stage 3, if we see, there is a significant benefit with the addition of adjuvant chemotherapy, the hazard ratio being 0.83 and a p-value of less than 0.05. So the role of adjuvant chemotherapy as per the latest meta-analysis is mainly in the stage 2 and stage 3. In stage 1B, we have to look out for the risk factors. The most important risk factor being tumor more than or equal to 4 centimeters, where they have shown that addition of adjuvant chemotherapy has resulted in a significant benefit in the overall survival, whereas the entire stage 1B, there was no significant overall survival difference. So stage 1A, adjuvant chemotherapy results more in harm than benefit. Stage 1B, risk factors, especially tumors more than 4 centimeters. This actually became the basis for all the newer trials, which I would be discussing further. A tumor more than 4 centimeters was one of the most common inclusion criteria in many of the targeted trials and the immunotherapy trials. So what are the preferred chemotherapy regimens which we have? We have the cisvinerilbin, cisplatin pemetrexed, or docetaxel or paclitaxels, or the gemcitabine. Gemcitabine is mainly used in the squamous cell, pemetrexed in the non-squamous histology, and various trials have shown the benefit of these chemotherapeutic regimens in the adjuvant setting. So this was all which was happening prior. But what is happening in 2026? So in 2026, everything is biomarker driven. So we have to test for at least for the EGFR, ALK, and PDL1 in the early stage lung cancer. If you are not doing NGS based testing, a minimum test of the EGFR, ALK, and PDL1 helps us to identify those patients who would benefit from this targeted therapy. So any stage can we avoid testing? Stage 1A is one where you can avoid testing, but still it's better to get it done when you have a tissue in your hand. It is always better to run the biomarkers. We don't know when the patient might metastatize and when you might not be able to access the tissue. So a minimum testing of EGFR, ALK, and PDL1 is important for the early stage lung cancer. And the indications for these testing is based on the trials which have actually led to the approval of targeted therapies. These three are bare minimum because we have approved targeted therapies for both EGFR and ALK mutations. And yes, we have immunotherapy for the PDL1 positive populations. NGS also can be done to identify other mutations such as the ROS, RET, KRAS. We presently don't have evidence to start any targeted therapy, but down the line, we are going to get some other evidence for all these targets. Once the metastatic setting evidence is there, then it actually moves on into the adjuvant and the neoadjuvant setting. So moving on to the first mutation, that is the EGFR mutated NSCLC, ADORA. adjuvant, and this is the adjuvant osimertinib trial, which was published in NEJM in 2023. This is the double-blinded phase 3 trial. Randomization was between osimertinib versus placebo. Osimertinib was given for 3 years, and the stages included was stage 1B to 3A, and only the common EGFR mutations, that is the exon 19 deletion or L858, were included in the study. The primary endpoint of DFS, if you see, the hazard ratio was very significantly different, with a hazard ratio of 0.27. 5-year DFS being 65 months compared to 28.1 months, nearly 3 times increase in the 5-year DFS rates. 5-year overall survival is also significantly better with addition of adjuvant osimertinib, 88 versus 78%, with a hazard ratio of 0.49 again. If you see the CNS disease-free survival, again an impressive hazard ratio of 0.24 with the addition of adjuvant osimertinib, and the majority of the benefit was in the stage 3A setting, 85% versus 67%. The stage 3A, which is the high risk group in the stage 1B to 3, if we consider 3A is one of the highest risk group, and this group actually had the best benefit with the adjuvant osimertinib addition. And also these patients, some of them have received adjuvant chemotherapy and some have not received adjuvant chemotherapy. But if you observe, if irrespective of the adjuvant chemotherapy usage, the hazard ratio for the use of adjuvant osimertinib is 0.49 and 0.47. So even if the patient hasn't received adjuvant chemotherapy, we can still go ahead and start with osimertinib and continue for 3 years if the patient tolerates. For those patients who have an EGFR mutated early lung cancer, stage 1B to stage 3A. And the most common toxicities which were observed in this trial were the diarrhea, dry skin, stomatitis, and paronychia, which were expected toxicities of osimertinib. Moving on to ALK positive NSCLC, the ALINA trial, which is the adjuvant alectinib. Again, a phase 3 randomized trial. Same stages, stage 1B to stage 3A are also included in this trial. 1B being the tumor more than 4 centimeters. This was what I was mentioning about, the more than 4 centimeters, an important inclusion for all these trials. Alectinib was given at a dose of 600 mg twice daily, given for 2 years. Osimertinib was for 3 years, alectinib for 2 years. And again, 2-year DFS, 93% compared to 63% with adjuvant chemotherapy alone. And hazard ratio of 0.24 with a p-value of 0.0001, which is a significant improvement in the 2-year DFS. The 3-year DFS is also significantly improved. And if we observe CNS DFS hazard ratio, we have seen osimertinib 0.24, 0.22 with alectinib in ALK positive NSCLC. So both the drugs in their respective targeted population, they are doing a good job in controlling the CNS disease, which is the most common site of recurrences in both the ALK and EGFR positive NSCLC, more so in the ALK positive NSCLC. And the risk of recurrence or death has been reduced by 76%, lower risk with use of alectinib as the adjuvant treatment in ALK positive NSCLC. And alectinib has shown benefit mainly because of its higher penetration into the CNS, which is not generally seen with the earlier generations of ALK inhibitors. And coming to the discontinuation rate, yes, there is a discontinuation rate of around 5.5% with alectinib, and grade 3 for adverse events were seen in around 18% of the patients in the alectinib arm, but there were no grade 5 events, and the most common were constipation, raised in the AST-ALT, or increase in the CPK levels. And those two are the trials were given as the evidence for the adjuvant treatment in a targeted NSCLC, that is the EGFR or ALK positive NSCLC. For what about the driver negative NSCLC? For driver negative NSCLC, the adjuvant immunotherapy trials which we have are the IMpower 010 and the Pearls Keynote 091 trial, which is of pembrolizumab. Both the IMpower and the Keynote have included stage 1B to 3A patients. Both have used immunotherapy for 1 year, and the comparator arm was best supportive care or the placebo in both the studies. And in the IMpower, surgery was followed by chemotherapy, followed by atezolizumab for 1 year. If you see the IMpower 010 trial, improvement in the disease-free survival, hazard ratio of 0.66 in the PDL1 more than 1% population. 5-year DFS is also better. Overall survival is also significantly improved with adjuvant atezolizumab for 1 year, hazard ratio of 0.43. But in the patients with the PDL1 of less than 50%, overall survival was not significantly beneficial with addition of adjuvant atezolizumab. So more than 50% PDL1, there is an overall survival benefit also with adjuvant atezolizumab. And EGFR mutated subgroup, some patients were included, but there is no benefit for the mutated subgroup, so not recommended for the driver mutated NSCLC. And if you see the PEARLS trial, the pembrolizumab 1-year trial, disease-free survival in all PD-L1 subgroups was significantly better with pembrolizumab for 1 year. Median DFS of 53 months versus 42 months. And in PD-L1 less than 1% subgroup also, pembrolizumab has shown an improvement in the DFS, hazard ratio being 0.78. Overall survival data is still immature, and the benefit with the pembrolizumab is irrespective of the PD-L1 status. So adjuvant atezolizumab benefit mainly the PD-L1 more than 1%. Overall survival benefit only in the PD-L1 more than 50% population, whereas pembrolizumab has shown a benefit irrespective of the PD-L1 status. So we also have some trials in the neoadjuvant and the perioperative chemoimmunotherapy. I want to cover them because they also part of the adjuvant treatment when we start as a perioperative approach. And in the neoadjuvant therapy, the main rationale for giving a neoadjuvant immunotherapy is for the treatment of micrometastasis, immune priming, which actually helps us in treating the tumor when it has been removed post-surgery. The immune priming effect of neoadjuvant therapy will give some more benefit, and also it helps in downstaging the tumor, which also results in an improved resectability. And surgical delays and post-op complications are also not higher with neoadjuvant therapies. So the main outcomes which are measured with neoadjuvant or perioperative immunotherapy are the pathological CR rates, where there is no residual viable tumors in the primary, or the major pathological response rates of less than 10% viable tumor in the resected specimen after neoadjuvant therapy. So Checkmate 816 is the neoadjuvant therapy only. This is pure neoadjuvant trial, not a perioperative trial, in which they have used 3 cycles of platinum doublet along with neoadjuvant nivolumab. So neoadjuvant nivolumab plus 3 cycles of chemotherapy followed by surgery. The PATCR rates were 24% versus 2.2% in the chemotherapy alone arm. Major pathological response was 36.9%. Event-free survival benefit was there, hazard ratio of 0.63. And 5-year overall survival was also beneficial with neoadjuvant nivolumab. So a short course of 3 cycles of neoadjuvant nivolumab plus chemotherapy has resulted in improvement in the EFS and overall survival. PATCR rates were higher. Major pathological response was also higher compared to neoadjuvant chemotherapy. Surgery was completed in around 83% of the patients with no increase in the complications. So if you are planning only for a short course of immunotherapy, neoadjuvant nivolumab plus chemotherapy is a way to go, which has shown beneficial irrespective of the PD-L1 status. And coming on to the perioperative chemoimmunotherapy, we have 3 trials with nivolumab, pembrolizumab, and durvalumab. The Checkmate 7070 and the Keynote 671 and the AGN trial for durvalumab all have included resectable NSCLC from stage 2 to stage 3B. And 4 cycles of chemotherapy plus immunotherapy was given as the neoadjuvant resection, followed by continuation of immunotherapy alone in the adjuvant setting. So the neoadjuvant nivolumab trial was only 3 cycles of nivolumab, but the perioperative trials have used 4 cycles of combination of immunotherapy plus chemotherapy, followed by surgery, followed by adjuvant, either of the nivo or pembro or durvalumab given for 1 year. And the control arm in all of these was surgery followed by placebo, which was given again for 1 year. And the endpoints were different, but most commonly it was EFS in all the 3 trials. Overall survival was also the endpoint in the Keynote 671 trial. So these are the outcomes of the 3 trials. The nivolumab trial, all the 3 trials, if you see, the hazard ratios are almost close by. Nivolumab hazard ratio 0.58 and pembro also 0.58, whereas durvalumab it is 0.68 for the EFS at 1.5 and 2 years. Pathological complete response was seen higher with nivolumab 25% compared to 18% and 17% with pembro and durvalumab respectively. Major pathological response again 35% and 33%, similar major pathological response. OS data we have for pembrolizumab, whereas it is maturing for the nivolumab and durvalumab trials. Hazard ratio of 0.72, significant improvement in the overall survival with pembrolizumab. So pembrolizumab both in the adjuvant and perioperative setting has shown an improvement in the overall survival irrespective of the PD-L1 status. So this is again the comparison of the Checkmate 816 with the Keynote 671 trial. If you see, the 5-year overall survival rates were 65% with the neoadjuvant nivolumab compared to 71% in the pembrolizumab trial. The hazard ratios are similar, 0.72. This is what we have to compare when we are doing a cross-trial comparison. The hazard ratio are similar for the adjuvant pembrolizumab compared to the neoadjuvant nivolumab trials. So This is summarizing the perioperative approach. For patients with a biomarker positive disease, that is a EGFR positive or ALK positive NSCLC, surgery is the first preferred option, followed by osimertinib adjuvant for 3 years if it is EGFR positive, or alectinib for 2 years if it is ALK positive. Chemotherapy can be given prior to EGFR targeted therapy for stage 2 to stage 3 if they are eligible for chemotherapy, but do not use immunotherapy for a driver positive NSCLC because there is no benefit in majority of the trials, either in the metastatic or in the early stage lung cancers. If it is a driver negative, any PDL1 preferred approaches we have or the perioperative nivolumab or pembrolizumab trials. If upfront surgery is done, we have the options of adjuvant atezolizumab or pembrolizumab, or we have the option of neoadjuvant nivolumab 3 cycles plus chemotherapy also, just the neoadjuvant therapy. If they are ineligible for the combination of chemoimmunotherapy, cisplatin based adjuvant chemotherapy is still a valid option for driver negative NSCLC. If they are ineligible for chemotherapy and only immunotherapy can be given, the preferred option should be giving either adjuvant pembrolizumab irrespective of PDL1 or adjuvant atezolizumab if the PDL1 is more than 1%. A small note on the Stage 3 NSCLC. Stage 3A NSCLC is the resectable or the borderline resectable population where the major role of neoadjuvant therapies or the perioperative immunotherapy, chemoimmunotherapy combinations play an important role in the management of stage 3A, a multimodality approach. But here is where we have the main role of neoadjuvant therapies. Stage 3B unresectable multistation N2 are usually, or the stage 3BC are generally managed with the definitive concurrent chemoradiation, followed by durvalumab as a consolidation or osimertinib if you have an EGFR positive NSCLC. So this is the NCCN treatment algorithm. For stage 1, preferred is surgery. Surgery is not feasible, SBRT. And stage 1B, more than 4 centimeters, we do have a role of adjuvant therapies like the stage 2 and stage 3. Stage 2, stage 3 resectable, driver mutation positive, target the driver, either osimertinib or alectinib, both of them are approved for the EGFR positive, ALK positive disease. If they are driver negative, neoadjuvant nivolumab plus chemotherapy or perioperative nivolumab chemo plus atezolizumab plus chemotherapy, or if the patient has undergone surgery, ineligible for chemotherapy, we can just use adjuvant immunotherapy. If the patients are eligible, we can use chemotherapy followed by immunotherapy also. And stage 3 unresectable, preferably to go with concurrent chemoradiation. So these are my conclusion comments based on the NCCN and ESMO guidelines. So driver mutation testing is very important to identify those patients who would benefit with the targeted therapies. And for those patients who do not have a driver positive, immunotherapy and chemoimmunotherapy combinations are the way to go for the early stage NSCLCs. Thank you.
Thank you, ma'am. Thank you for that comprehensive and clinical relevant talk. We now proceed to our next talk. I invite Dr. Bala Stalin Chaudhary, Chief Medical Oncologist, Hemato-Oncologist and BMT Physician, Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam, to share his insights. So please go ahead.
Yeah. Thank you. Am I audible? And
Yes.
The PPT is clear, right? Okay.
Yes.
So over the next 15 minutes, I'll be talking on the precision oncology, most often in the targeted therapies in the advanced non-small cell lung carcinoma. I'll be interrupting in between the neoadjuvant therapies and adjuvant therapies and the panel discussion on that. And I'll be interrupting and taking the talk on the precision oncology in the advanced NSCLC. So this is the overview. So we all know that molecular classification, so we have been doing since almost more than a decade, especially in the adenocarcinoma. And almost in the Indian context, 64% of the lung adenocarcinomas harbor a targetable mutation. And majority of the times in the Asian population, the 35 to 40%, and often if you take females alone, it accounts for around 60% or EGFR mutation positive. And if a patient has a driver mutation and they are treated with targeted therapy, their median overall survival is significantly better than the patient doesn't having a driver mutation. So what is a driver mutation? We all know that somatic mutation in the genes which are critical for the cell growth and survival. So there are driver mutations and the passenger mutations, but driver mutations are essentially needed for the cell growth and survival. So what happens is there is this type of oncogene addiction. The mutated protein is stuck on. Cell survival depends entirely on this one signal, and it creates an Achilles heel. Blocking the signal kills the cancer cells selectively. So there are certain molecular testing strategies straight away from the PCR to FISH to DNA sequencing, but the standard as of today is doing both DNA and RNA NGS, because DNA NGS will miss certain tissues, and it has a low sensitivity and need for more than 10% tumor cellularity. So doing a DNA and RNA NGS also picks up various fusions. It is broad sensitive, identifies fusions and novel variants, quantitative, and detects intronic rearrangements also. It is the gold standard comprehensive testing as of now. So for ALK and PDL1, we can get away with doing IHC. So these are the various diagnostic toolkit available with us. So DNA sequencing and the has a low sensitivity, and DNA allele specific PCR, and now almost all across major institutes of all the institutes which are practicing oncology. So the next generation sequencing, NGS, DNA and RNA based, has become the standard of care in the management of lung cancer. There is certain advantages of doing a liquid biopsy. It is non-invasive, faster, assesses total tumor heterogeneity, allows for the longitudinal monitoring also, but there is a high risk of false negatives associated with advanced disease bias and can't test PDL1. For the liquid biopsy, now we have a platform available called Garden 360, where we can pick up more number of mutations compared to the tissue also. But if a liquid biopsy is negative, it doesn't rule out anything. A tissue biopsy is still strictly required due to the inherent risk of the false negatives associated with the liquid biopsy. Coming to the targetable landscape of these non-small cell lung carcinoma genotypes, so there are kinase mutations like EGFR and BRAF, core translocations like ALK, ROS1, RET, and other mutations like KRAS, and other fusions like NTRK fusions, and mutations like HER2 and MET exon skipping mutations. So these are the various mandatory biomarkers which need to be tested, because all have some sort of targeted therapy available which can produce dramatic responses and also improves the survival of the patients. Why this is needed in advanced non-small cell lung carcinoma? Because a patient who is having a targetable driver mutation and who is treated with targeted therapy tend to have an extremely longer median survival compared to the patients who doesn't receive the targeted therapy or who doesn't have a no driver mutation. Coming first to the EGFR mutations. So in US, the incidence rates range up to 15%, but in Asians, it can range anywhere between 40 to 62%. And majority of the times, 80 to 90% of the times, it is classical mutation, which is exon 19 deletion and L858R. And 50 to 60% can have a T90M mutation after treatment with the first and second generation TKS. The exon 19 mutation and L858 are sensitive to all available EGFR tyrosine kinase inhibitors. T790M is sensitive only to osimertinib, and exon 20 insertion are resistant to all TKS except for mobocertinib and amivantamab. And for rarer mutations like in the exon 18, where G719X and L861Q, S768I, we typically account for around 3 to 4% of the cases. We typically use afatinib or in some cases osimertinib. There is an accelerated evaluation of EGFR targeted therapy right from first generation, which have a reversible ATP competitiveness to irreversible inhibition by second generation afatinib and dacometinib. Thereafter, improving with the irreversible and CNS penetrant drugs like osimertinib. And now we are in the era of combination therapies, either combination chemotherapy with osimertinib or amivantamab, lazertinib, which are the current standard of care in the treatment of frontline EGFR mutated lung cancer. So first generation tyrosine kinase inhibitors like erlotinib and geftinib offers a median progression-free survival of around 10 to 13 months with a median overall survival of 20 months. But over a period of time, 50 to 60% will acquire a T790M resistance. And second generation will produce a slightly better progression-free survival up to around 15 months, but there is no classically any difference between the first generation and second generation tyrosine kinase inhibitors. And third generation tyrosine kinase inhibitors produce an progression-free survival of around 19 months with an overall survival of ranging around approximately 39 months. And FLORA trial has shown benefit of osimertinib compared to the first and second generation tyrosine kinase inhibitors. So these are the primary drivers and the architecture of the acquired resistance. So the primary targets are the EGFR exon 19 deletions and exon 21. After that, the EGFR dependent resistance can happen over a period of time. like acquired C797 mutations, which block osimertinib binding at the active site, and EGFR amplification also drives the progression. Or EGFR independent bypass mechanism can happen over a period of time, leading to MET amplification is one of the common escape hatch. Or in rarer cases, around 4 to 5% of the cases, histological transformation to small cell lung carcinoma, which is associated with retinoblastoma and TP53 loss or squamous cell carcinoma, can happen. So the first line decision matrix. So we have three combinations: either use a FLAURA combination, which is osimertinib monotherapy. So or FLAURA 2 combination, where osimertinib with platinum pemetrexed combination, or amivantamab plus lazertinib, which was used in Mariposa. So there is no head-on-head comparison. But if you cross-compare it, the progression-free survival rates among osimertinib, platinum pemetrexed, or amivantamab lazertinib combinations are more or less same. So usually osimertinib is indicated for standard or indolent or low risk disease. For a standard for a high tumor burden and CNS involvement, the combination between the platinum pemetrexed and osimertinib. And for patients who are multi-pathway targeting and for overall survival benefit, we need to use a combination like amivantamab and lazertinib. So also the molecularly high risk, that is co-occurring TP53 mutations, the nature of the progression, the indolent profile nature of the disease, and the tumor burden and the CNS metastasis. These are all helps in the risk stratification of the patients, and these help in guiding and treating our decision either with a monotherapy or with a combination therapy. So combinations offer up to a 6.6 month extension in median progression-free survival, but they comes at the cost of more side effects, more amount of toxicity too. For example, amivantamab plus lazertinib drives a 75% grade 3 adverse event rate requiring VTE prophylaxis and intensive dermatological management, whereas osimertinib plus chemo combination drives 64% grade 3 adverse events with the 43% discontinuation rate heavily linked to the maintenance pemetrexed. So there is no universal default. Treatment must be shared decision, heavily weighing the patient frailty, health literacy, and willingness to trade acute quality of life for delayed progression. So the most common toxicities associated with amivantamab and lazertinib are the infusion-related reactions, cutaneous toxicities, which is requiring a Cocoon protocol like oral tetracycline and topical clindamycin chlorhexidine, which has the severe dermatological events, and almost all need a prophylactic anticoagulation because we in 37% of patients VTE can occur. Osimertinib and chemotherapy is associated with higher rates of neutropenia and anemia, and it can thus lead to maintenance fatigue and significant decrease in the quality of life of the patients. So what are for the uncommon mutations like exon 20 insertions? We can use chemotherapy plus amivantamab. In the subsequent lines, if not used, amivantamab can be used. For rarer mutations, as we have discussed, we can use amivantamab lazertinib combination or afatinib or osimertinib, or also equally alternatives. So for a progression beyond EGFR first line, so if there is an actionable driver mutation, we can target it like MET amplification. If there is a histological transformation, we use a different chemotherapy. If no actionable driver or no transformation, there is a data with Mariposa 2 trial where amivantamab plus chemotherapy provided a good progression-free survival. What are the emerging horizons in the EGFR subset? There are 4th generation TKIs which are available. Newer antibody drug conjugates and VEGF PD-1 bispecifics are also being developed for the treatment of these things. So coming to the ALK, so which is seen in 3 to 5% of non-small cell lung carcinoma, but in India, it is slightly more in incidence, around approximately 6 to 7%. So younger age of onset and non-smokers, adenocarcinoma, but one of the most profound thing with ALK is the higher CNS penetrance. These are the various drugs which are available for treating ALK: crizotinib, ceritinib, alectinib, brigatinib, ensartinib, and lorlatinib, which produce a good, decent overall survival. If you talk about the driver mutant lung cancer, one of the best driver any advanced lung cancer patient can have is the ALK rearrangement. Similarly, crizotinib and ceritinib have a very limited or moderate CNS activity. From alectinib, all have a very good, excellent CNS activity. So while treating an ALK rearranged and non-small cell lung carcinoma, we all know that we need to choose a drug which penetrates the blood-brain barrier because it is the disease which ultimately relapses in brain or can have a CNS at presentation itself in majority of the cases. So most common TK which is favored is the lorlatinib because Crown has shown a significant benefit compared to the crizotinib. The median progression-free survival is not reached, and almost 2/3 of the patients had crossed a 5-year progression-free survival. Other acceptable alternatives are the alectinib and brigatinib, which shown their efficacy in the LX-JLX trial and the ALTA-1 trial. So this is the crown trial. The hazard ratio of 0.19, 5-year progression-free survival rate was different by 52%, and the median progression-free survival was not reached. And the intracranial efficacy was also significantly better with the lorlatinib, and also it is better with the alectinib and brigatinib compared to the crizotinib and ceritinib. But what is the problem with all these ALK inhibitors is the various side effects they produce. For example, lorlatinib produces neurological side effects like cognitive effects, mood, speech. Crizotinib produces visual trailing light flashes, and they can produce a sinus bradycardia and QTC prolongation, transaminitis, and musculoskeletal symptoms too. So one of the specific side effect which need to be noted with brigatinib is the early pulmonary toxicity. So there is a step-up dose of using 90 mg initially for 1 week. If patient tolerates it and there is no toxicity either, the step-up dose to 180 mg can be done. This need to be specifically noted with respect to the brigatinib. Lorlatinib has a specific side effects like hyperlipidemia, which can be controlled with aggressive use of statins. It also produces CNS effects and neurological side effects. So if at all they are severe, we need to hold the treatment until improvement, or you can resume at a lower dose of 75 mg, because we have a data to say that dose reduction to 75 mg does not compromise long-term efficacy as per the Crown data. So post progression, we can use platinum-based doublet chemotherapy. Coming to the other beyond ALK and both ALK and EGFR put together account for around 40 to 45% incidence of driver mutations. Beyond this, there are rarer mutations like ROS1 rearrangements that can occur in 2 to 3% of NSCLC and never smokers, and they have also higher CNS penetrance. And there are various drugs which were tried straight away, starting from crizotinib to entrectinib and repotrectinib and trilaciclib. All 4 drugs have shown significant activity with producing an overall response rate of approximately 60 to 90%, and the median progression-free survival, especially with repotrectinib, entrectinib, and trilaciclib, is good, and with crizotinib is also, and which is a drug which is available with us. We use typically. But what is the difference between the crizotinib and entrectinib is entrectinib can have a good CNS penetration. The other rearrangements we look for is the RET rearrangements. To treat that, we have 2 drugs which are called sulpercatinib and pralsetinib. 1 to 2% of non-small cell lung adenocarcinomas can have RET rearrangements. They occur in non-smokers. The Liberto 301 trial and Arrow trial has tested the sulpercatinib and pralsetinib. Both produce a significant overall response rate of around 80% and a progression-free survival of approximately 20 to 25 months and a median overall survival of 44 months for a patient with RET rearrangement. So either sulpercatinib or pralsetinib is the drug of choice. Another rare mutations we check is the MET abnormalities, which is the MET exon 14 skipping mutation, can happen in approximately 2 to 3% of the cases, or MET gene amplification can happen, or CMET high protein expression is there. For patient with MET exon 14 skipping mutation and MET gene amplification, we can try capmatinib and topoteninib, because Geometry 1 vision trials had shown significant survival benefit with the use of these tyrosine kinase inhibitor. More rarer mutation is BRAF compared to other driver mutations, which BRAF mutations are less common, and of them there are 2 classes. One is V600E and non-V600. For V600E, we can treat with dabrafenib and trametinib or encorafenib plus binimetinib. They are typically more common in smokers compared to the other driver mutations. If you see the other driver mutations like EGFR, ALK, and ROS, they are more common in non-smokers than smokers, but BRAF is more common in smokers than non-smokers, and it accounts for approximately 1 to 2% of the non-small cell lung carcinoma. KRAS, so this is one of the problematic thing, and for which there was a very much problem in developing the drugs, because all the approved drugs had shown not much great benefits in terms of the survivals or the response rates. And it can happen in one of the most common mutations. It can happen in 20 to 25% in lung adenocarcinoma. Majority of the times, it is the G12C proportion accounts for the majority. It is smoking associated, and the TKs which are available are approved in the second line. In the first line, we typically tend to treat them with either chemotherapy or chemoimmunotherapy. The tyrosine kinase inhibitors which are used in later lines are the sotorasib and the adagrasib. HER2 one of the least common mutations where we can use none of them are used in the frontline setting. Majority of the times we reserve it to be treated in the later lines, especially with the availability of the trastuzumab deruxtecan. So this is the agnostic therapy. We test for NTRK fusions across all cancers. We also test in lung cancer, where we have availability of entrectinib in India, where we can use it for the NTRK fusions, and you can use it in the frontline setting. So coming to the CNS metastasis, EGFR, ALK, ROS are the mutations which can have a higher incidence of CNS metastasis. You need to choose a tyrosine kinase inhibitor which can have a intracranial activity. So when you are treating any patient with these personalized therapies in the precision oncology, one of the most important thing you need to learn is the development of the mechanism of resistance. This can happen because of four things. One is on-target resistance, that is secondary mutations in the target kinase prevent drug binding, or can have a bypass signaling, so activation of other pathways, or phenotypic transformation, the adenocarcinoma changes into other subtypes because of epithelial mesenchymal transition or acquiring other mutations like retinoblastoma and the p53, or pharmacokinetic resistance like increased drug efflux and gene amplification causing increased target production. So what is the optimal sequencing? Test first, then treat. Do always have a immunotherapy caution in the driver positive because they have a very limited efficacy. So always, if at all you have a time, you first test for these driver mutations before initiating the immunotherapy. Always do a rebiopsy progression and document the mechanism of resistance. Generation sequencing matters, preferably if for across EGFR and all. Prefer always the third generation tyrosine kinase inhibitor, and for KRAS, use the tyrosine kinase inhibitors only in the second line, not in the first line. So these are the immunotherapy in driver mutation. So caution is advised. So can have toxicity without providing much benefit. So across all subtypes of driver mutant lung carcinoma, except for the KRAS, there is no better response rate with the immunotherapy. So liquid biopsy we have dealt, and what are the emerging agents? So we can have the antibody drug conjugates, trastuzumab deruxtecan, we are using it in the HER2 positive drug, and next generation RAS inhibitors, and the TRK sparing ROS1 inhibitors and the bispecific antibodies are also being developed in the future, which may come into the frontline treatment of the lung carcinoma. So these are the 10 important principles for treating a driver mutant lung carcinoma. You always test before treat. So driver targeted therapy first, avoid immunocheckpoint inhibitor in driver positive disease, sequence for resistance, always do rebiopsy at progression. CNS must be considered in the frontline itself. KRAS is different. So ADCs are expanding the indication for the treatment, especially for the HER2 positive disease. So if at all you do a early stage disease, you do an adjuvant TKA, especially osimertinib and alectinib. Preferably for rarer driver mutations, always try to enroll the patient into trial. There are other mutations which are called as prognostic modulator. They don't have a targeted therapy like TP53, STK11, and KEAP1, where they tell us whether the immunotherapy will work in a better way or not, but they specifically doesn't have any role as a targeted therapy. So they are all the clinical summary of all the drugs we have discussed till now. So to conclude, see, the present and future of non-small cell lung carcinoma is molecular and completely in the precision oncology. Molecular profiling has transformed non-small cell lung carcinoma from single disease into a collection of distinct molecular entities. So now it is mandatory for all patients to undergo a NGS to test for drivers to treat with driver mutation. So we Indian oncologists must champion a comprehensive NGS testing and advocate for access to the most effective therapies for our patients. Clinical trial participation remains the best option for rare drivers, resistant disease, and novel combination strategies. In oncology, the right drug for the right patient at the right time is not a slogan, it is the scientific mandate. Thank you.
Thank you, sir. Thank you for that excellent overview. So we now move into our first panel discussion. I would like to invite our moderator for this session, Dr. Meher Lakshmi, additional professor and the head of Department of Medical Oncology, NIMS, Hyderabad, and joining as panelist, Dr. Aparna Dhar, Senior Director, President Oncology and Genetic Counseling, Molecular Oncology and Cancer Genetics, Max Healthcare Delhi, Dr. Jojo Anatoni, Assistant Professor Surgical Oncology, Amla Institute of Medical Sciences, Thrissur, Dr. Suma Devraj, Consultant Medical Oncologist, Solapur, Dr. Sandeep Majumdar, Consultant Medicine Oncologist, Apollo Cancer Center, Bhubaneswar. Dr. Meher ma'am, over to you to lead the discussion.
Thank you. Thank you so much. And I'll start to share. Let me start sharing my slides. I hope my screen is visible.
Yes, ma'am, visible.
Yes. So after two very good lectures from by Dr. Rachna and Dr. Stalin, let us move to the panel discussion. This is, mainly a discussion on what we do usually. It is actually exhaustively discussed by Dr. Rachna, the neoadjuvant treatment strategies. So the central clinical question in this panel discussion is for a fit patient in the resectable stage 3 and stage 2 NSCLC. Should we go for perioperative or adjuvant immunotherapy after surgery? These are the key central questions. And each one has their own advantages and disadvantages. Let me quickly rush through the major clinical trials and salient points. Then we'll start discussion. I have 10 questions for all the panelists. See, if we see perioperative immunotherapy, that is neoadjuvant therapy followed by surgery, you can deal with LD micrometastasis. We can assess the chemosensitivity, and we can check the PCR, which is access surrogate endpoint. It helps in downstaging, that is better RO resection. And there are certain regimens where oral survival is confirmed. And adjuvant only what are the advantages? Surgery can be done without delay, and the pathology can guide adjuvant treatment decision. And yes, there's simpler sequencing, and TK sequencing is also easier. So the key decision factors are the stage, the biochemical, the molecular markers, and the surgeon confidence, and all the other factors like performance status, comorbidities, function, etc. And the important is the multidisciplinary team consensus. These are the landmark trials. Dr. Rachna has extensively discussed all the clinical trials. If you see, we have in as neoadjuvant setting, we have a neoadjuvant nevo and neoadjuvant perioperative nevo. Neoadjuvant nevo followed by surgery, where the PCR rates, as Dr. Rachna suggested, PCR rates are quite high when neoadjuvant nevo was given. PCR rates as high as 24 to 25%. Pembro followed by surgery for neoadjuvant. There is a study, but there was one study where Durva was given as adjuvant therapy. That was a negative study. So there is no role of giving Durva in the adjuvant setting, but if you start in the perioperative setting, it can be continued, and that shows a very good response. The other trials of adjuvant setting were ADO and Pembro. So these are the what about EGFR and ALK mutation? Mutated lung cancer very good DF 0.2% hazard ratio, 5-year 88% versus 78% per term, and CNS disease-free survival also hazard ratio 0.24, and even in stage 3A patients, the OS is there is OS benefit. And the largest OS gain in any subgroup is in patients with stage 3A. And and in I'm sorry, something happened and suddenly it stopped. I'll start sharing again. Yes, I hope my slides are visible.
Yes, ma'am, visible.
Yes. What about R positive? We have the Alina study where adjuvant alectinib was administered for 2 years, and there's good and DFS hazard ratio is 0.24, very impressive as that in EGFR mutated lung cancer. So these are all the perioperative trial designs. Dr. has described all these both the pembro, all the study design, and these are efficacy if you see checkmate where Nivo was given keynote and all the three which are already discussed, and these are the key key points where periop. If you see the keynote 6.7 OS update, this is one which has shown which has 3 of 12% plus 4%. There is an impressive OS. And pathological response, does PCR predict long-term survival? If you see this, 5-year OS with PCR is 95.3%. This is the checkmate as exploratory analysis. 5-year OS without PCR is around 58%. So there is a difference. And 24. So there's definitely a benefit in those who get a pathological CR. And yes, this you can see later. So let's come to the questions. The first points put together for a fit patient with resectable stage 2 or stage 3 NLCLC, where you don't see a mutation in EGFR at all. Should perioperative chemoimmunotherapy be the default or adjuvant only immunotherapy after surgery? Dr. Aparna, would you like to take
Hi, sorry, I didn't catch the question.
I don't know what is happening.
Sorry, Dr. Meher, could you repeat the question?
I don't understand why. I mean, there's so many glitches, and I'm not able to share the screen properly. Rukmani, can you share from your end? Madam,
Yes.
the question is, which do you prefer, neoadjuvant or adjuvant?
Okay. So I'm technically not a medical oncologist, but from what I have learned,
Madam, then you can
okay,
take some other question if you
I'll
don't
take the
mind.
molecular, yeah, I'll take the molecular part as and when.
Yeah. I'm sorry about that.
No, that's all right.
Dr. Suma, can you take the question?
Yes, ma'am. Good evening, ma'am. So, in a patient of stage 2 to stage 3 lung cancer who is operable, comparing perioperative versus adjuvant, I would prefer giving a perioperative chemoimmunotherapy approach, considering we have OS data also from one of the perioperative trials, like pembrolizumab has OS data. Also, giving perioperative, we also get to know whether PATCR or major pathological responses attained. That could be prognostic as well.
Yes, Dr. Sandeep, any other thoughts? And Dr. Sandeep, I have a question. If you're given a choice of, we have Nivo, Pembro, and Durva, what is your choice given all the three immunotherapy agents? Dr. Sandeep is there? Dr. Sandeep is not. Dr. Suma, what
Yes,
is your choice of the agent?
ma'am, all three have almost similar outcomes, but OS data is available with pembrolizumab. So probably I would prefer pembrolizumab just slightly over the others.
Because you're impressed with the OS data. Okay. And given the availability of generic, do you see the CR? The PAT CR rates are quite high with Nivo.
Yes,
So,
ma'am.
is there any preference for Nivo?
If finances are to be considered, like if the patient cannot afford the pembrolizumab, then probably nivolumab, considering PAT-CR rates are quite high in the neoadjuvant trial. That would also be an option, ma'am.
Doc-
Like very slight
Yes.
difference between the three.
Dr. Sandeep is not there. Rukmani, may I know whether Sandeep is there or not, Dr. Sandeep?
Yes, ma'am. There's
Okay. So this is the perioperative versus adjuvant choosing the strategy. Both perioperative Nevo or Pembro is category 1 and preferred over adjuvant only approach. If you see all these trials, they show there's benefit with perioperative chemotherapy. And it's safe and when it's preferred, when patients already have on surgery, we plan for adjuvant therapy. And if pathological computer and chemotherapy, we continue for 1 year or can be safely omitted given excellent response. Dr. Sandeep is there?
Yes, I'm here only.
Supposing the patient HCR, as you have seen, there are two studies. One is, the one, the beyond one, they gave only as neoadjuvant. The patient achieves PAT-CR. Do you want to continue or do you want to, you think can be omitted?
No, I think we should continue because we have to follow the protocol. That's why we get the better overall survival.
So most of the protocols, they have continued as perioperative therapy for 1 year beyond. And so even if the patient achieves PAT-CR, we can continue as per the trial protocol for 1 year. And we can do CT, DNA later on, but that doesn't decide, we need to continue. And next question, for a patient with stage 3A, single station N2 non-small cell lung cancer, should we pursue perioperative chemoimmunotherapy followed by surgery or definitive concurrent chemoradiotherapy with Durva consolidation? Sir, Dr. Jojo Anthony Sebastian, can you take this question, sir?
Yeah, sure, madam. Actually, in a single site N2 disease, we can consider perioperative chemoimmunotherapy followed by surgery, as long as the node is not bulky and it's not infiltrated. And if we can do a lobectomy, then surgery definitely is in play in N2 disease after chemoimmunotherapy.
Okay. Sir, in your experience, how frequently you see such patients and how frequently is surgery feasible in such patients?
In single,
We just want to know your experience.
In single station N2, it is feasible. But
Yes.
technically, if you ask me, surgery after immunotherapy technically is more challenging. Like we do VATS lobectomy as well as open lobectomy, but we've had to convert quite some number of these patients because the nodes which are diseased, they'll have some fibrosis, there'll be some inflammation around them. Usually the field becomes a little more messy, and I feel that surgery becomes more challenging after neoadjuvant in these patients. But we've had some patients who actually drop out, they don't come to the operating table at all after immunotherapy as well. So we've seen both spectrum. It is not really very easy to deal with this disease. Yeah, at that.
Yes, yes. And given the excellent results with the concurrent chemotherapy followed by Durva consolidation, if the patient can afford Durva, if the patient cannot afford, the first thing, that is perioperative followed by surgery, would be a good option. The patient, if you have an affordable patient, do you send them for CCRT followed by Durva consolidation, sir?
Yes, actually, I don't think we get a lot of patients who would afford durvalumab, but we don't have real world experience with many of them getting durvalumab and CCRT.
Yeah. Thank you, Dr. Jojo. And surgery versus definite CCRT. Yes, we need to choose on a case-to-case basis. If there's single station N2, we can opt for perioperative chemotherapy followed by lobectomy or pneumonectomy, and multi-station definitely CCRT followed by Durva. So many studies with backup. And next question, in an EGFR mutated, completely resected stage 3A patient, should adjuvant platinum chemotherapy be given before starting osimertinib, or should osimertinib be continued directly? Dr. Suma?
Ma'am, if we consider ADORA trial, there both the arms,
Yes.
be it the osimertinib plus chemotherapy arm or the osimertinib alone arm, there was no difference in their outcomes in the hazard ratio in the OS. So,
Yes.
if the patient is fit and there are no comorbidities, if he is able to tolerate chemotherapy, I would give the option of chemotherapy with osimertinib.
Okay.
But osimertinib alone is also a preferable option.
Yes, totally agree. And is there any, I mean, how do you select? Yeah, yes, I said if fit patient, you like to give chemotherapy and osimertinib. Dr. Sandeep, any change in your thoughts?
As the trial says, only osimertinib is good enough, so I like to continue only with osimertinib.
Okay, you like to start only on osimertinib. If you ask me personally, if I see a patient, yes, Dr. Suma suggested, young fit patients, I would definitely give them the benefit of chemotherapy, 4 cycles PEMSIS followed by osimertinib. And unfortunately, most of these patients are elderly patients. Uh, Elderly patients. Those all those patients whom we come across in the yes, proceeding with the preceding is reasonable for stage 3 and 2. And the most important essential component is the TK. Biomarker EGFR 3. What is optimal adjuvant? The upper connections because he's a medical
Hello?
oncologist.
Hello?
Hello, yes. May I know who is speaking? Yes, Dr. Sandeep, can you take this? Dr. Sandeep or
Yeah.
Dr. Suma?
Actually, network out of this time.
Yes. The patient undergo EGFR will take PDL is 30% decided. And what is your optimal adjuvant treatment that you will give?
Uh,
Or Dr.
EGFR,
Suma?
Okay.
EGFR negative.
Okay.
ALK negative.
In a patient who is now refused neoadjuvant therapy, direct or surgery has been done. Markers, as we know, it's EGFR and ALK wild type, PDL1 of 30%. Now, optimal adjuvant strategy would be to start with 4 cycles of chemotherapy, cisplatin-based chemotherapy, followed by immunotherapy, either an atezolizumab or pembrolizumab. Since PDL1 is 30%, even atezo would work well. Pembrolizumab is also an option.
And patient choice can proceed. And the next question: a patient has resected stage 3, a squamous cell carcinoma of the lung. Again, the EGFR ALK wild, PDL 40%. What is the approach? How is the approach different from non-squamous histology, and which regimen do you prefer in squamous cell carcinoma? Dr. Suma or Dr. Sandeep?
So, ma'am, in squamous cell carcinoma, the only thing I would change would be my chemotherapy backbone. So, instead of
Yes.
pemetrexed with cisplatin, I would go with gemcitabine or paclitaxel. Again, depending on the fitness of the patient. With that, immunotherapy.
Yes. What about immunotherapy? What about immunotherapy?
The trials have taken, both the trials have taken squamous cell carcinoma, ma'am. So, either an atezo or a pembro would be fine.
The preferred. Yes, I agree with you. So squamous histology that does not change the perioperative chemotherapy strategy. You should avoid PEM and use MCIS or cisphenoidalbine as the chemotherapy backbone, or as you said, Paclitaxel. And this is a 74-year-old patient, PS1, resected stage 3 NSCLC, mild COPD and controlled hypertension. Is perioperative chemotherapy appropriate or should we default to adjuvant strategy only? What is your take, Dr. Majumdar? And one question to Dr. Jojo Anthony. Would you like to operate on this patient, 74-year-old with stage 3 NSCLC? The first question.
Ma'am, I think it's the question has it says already been resected. So I think
this is resected, but my question, I mean, after this, I got a doubt actually. Supposing if in a real world you have a patient.
FEV1 of 58%,
Yes.
usually is with mild COPD is usually below the cutoff for a fitness for a lobectomy.
Pardon, I couldn't hear.
It's actually below the cutoff for a lobectomy, the
Okay.
FEV1. So
Yes.
we could do a cardiopulmonary exercise testing and see, but in mostly I don't think this patient would be a candidate for surgery with the FEV1.
Yeah, that is what when I don't know how I framed this question, but now I'm seeing it's difficult. I thought I should ask you instead of the medical oncologist. Yes, we can skip this. And the next, resected stage 3 NSCLC, NGS turns out as KRAS G12C mutation. Should adjuvant targeted therapy with sotorasib or adagrasib be used, or what is the role of immune checkpoint inhibitors in KRAS mutated resectable disease? Dr. Suma or Dr. Sandeep?
So, ma'am, in adjuvant setting, there is no data for TKS for KRAS mutation, and the trials have taken patients with KRAS mutation. There is no exclusion criteria as such. And if we consider immune checkpoint inhibitors in KRAS mutation, if we extrapolate from the advanced disease, KRAS mutants do well with immunotherapy. So probably we expect them to do well even in the adjuvant setting. At least this is just extrapolating from the advanced setting data.
Can I just
Yes,
add a
excellent.
comment
Agree
here?
with you.
Sorry, can I add a comment here, please? A partner here.
Yes.
With the KRAS G12C, you also have to be careful of co-mutations as KEAP1 and STK11. So while KRAS G12C are known to be more immunogenic and have a good response to immunotherapy, when we are doing an NGS, please make sure that you look out for the STK11 and the KEAP1. That does influence a response to immunotherapy, especially in this particular subset.
In what way does it, does it alter, madam?
Yeah, so a KEAP1 and an STK11 actually is a resistance mechanism to immunotherapy. So even in the presence of a KRAS G12C, which is known to create a hot immune environment, which means ideally immunos should work, if they have a co-mutation of KEAP1 or STK11, we've seen that the responses are much less and unfavorable versus just KRAS G12C on its own. It's a resistance mechanism to immuno.
Okay. So we need to check. That's a very good point. Thank you, madam. Thank you for the excellent inputs. So though KRAS G12C doesn't alter, we should need to check for co-mutations before deciding on immunotherapy.
Absolutely.
That is a point that we learned from them. And next question is, there was a patient who underwent surgery. 3 weeks post-op, the patient recovered well, but NGS results are still pending. Only EGFR PCR result is available. Should you start on H1 chemotherapy or wait for further biomarker results? Dr. Suma, Dr. Sandeep, do you wait or can we proceed for chemotherapy, H1 chemo? What do you usually do?
So, ma'am, if the 3 weeks post-op and patient has recovered well and if he's fit enough to tolerate chemotherapy, I would probably start with chemotherapy, wait for the ALK report to decide on the further course, whether patient is eligible for, as it is EGFR is negative. So the only options left after chemotherapy would be if ALK positive alectinib or immunotherapy. So personally, I would start with chemotherapy.
Yes, so
wait.
And then wait and plan immunotherapy or further
Or an
TK
alectinib.
based on the
report.
So yes, these are whether simply we need to all the markers, especially EGFR before survive CGT and no how do you see do you I mean are you in this I mean this about ctDNA, can you summarize?
Dr. Meher, I'm so sorry the line broke. Could you please?
Dr.
Yeah, sorry.
Voice is breaking, ma'am.
Yeah. Okay, so I'm guessing, do we use MRD in particular in lung cancers today? I think that's what the question is.
What is role of MRD?
This is honestly an evolving field, and I think ctDNA positivity at this point is clearly prognostic. It ideally is indicating a high risk of recurrence, but I don't think we're ready to act on it. I think, like, with colorectal cancers, you've got trials that show that if it's ctDNA positive, like MRD, minimal residual disease positive, then we know that we escalate. But I think with lung, be the TracerX trials, and there've been a couple of other trials, I do not think they've given us clarity. It is an evolving role. So today in lung cancer, to escalate, de-escalate, I would not depend on MRD testing. We're not there just yet, especially when there's no correlation with any radiological recurrence or progression.
Yes, thank you, madam. Thank you for your inputs. Based on ctDNA alone, without imaging showing evidence of recurrence, we do not start therapy. But that definitely has a prognostic value, and we need to enhance the surveillance measures. We need to intensify the follow-up. So these are the treatment decisions. Three. We need to do mandatory molecular markers, especially EGFR, ALK, and PDL1. If there's EGFR mutation or ALK rearrangement, for ALK positive targeted adjuvant treatment only. The surgery was meant for 3 years, ALK was selected for 2 years. Adjuvant chemo is an option, and
Sorry for disturbing.
with no perioperative immunotherapy is contraindicated. But
your voice is breaking, ma'am.
For those patients who are molecular marker and for chemo, we can opt for Evo or Pembro, or if the patient is eligible, can go for surgery followed by adjuvant Pembro, or it is less than 1% or clinical trial. Thank you. I thank all the panelists for their active participation. Thank you, one and all. With this, I would like to end the. How do I stop my slide sharing?
Thank you to panelists for that engaging discussion. any of the participants having any query, drop your query in the chat box. Now we move on to our second panel discussion. I invite the moderator, Dr. Ashish Upadhyay, Consultant Medical Oncologist, Fortis Hospital, Kolkata, along with the panelists, Dr. Parag Roy, Consultant Medical Oncologist, Tata Men Hospital, Jamshedpur, Dr. Satya Sadhan Sarangi, Senior Consultant Rashika, Chairperson, Department of Radiation Oncology, Sir Ganga Hospital, New Delhi, Dr. Ritika Mena, Assistant Professor Pathology, AIIMS Vijaypur, Jammu. Now I would like to hand over the moderator, Dr. Ashish Upadhyay. Over to you, sir.
Good evening. Thank you, everyone. Sorry, good evening. So am I audible?
Yes, sir, audible.
So can someone please share the slides?
Yes, sir.
So I hope all my panelists are here. Dr. Parag, Dr. Satya, Sika Madam, and Dr. Ritika.
Yeah. Yeah.
So, okay, we'll start with the case. We'll be doing a panel discussion on lung cancer. So next slide. So this is a 42-year-old male, non-smoker, admitted with cough, chest pain, and shortness of breath. PET scan was done, which showed right lower lobe mass with pleural effusion, with extensive pleural deposits, and there was also right peribronchial and hilar lymph node. Next slide. This is the PET scan report of the patient done in February 2024. Next slide. The biopsy from the right lower lobe mass was done, which came well differentiated adenocarcinoma. Next slide. And again, EGFR L cross was done. EGFR by PCR, L cross by FIS was done, and all were negative. Next slide. So this patient was given 6 cycles of pemetrexed carboplatin. Next slide. This is the PET scan after 6 cycle of PET scan. Next slide. So basically, these are the two PET scan. Left one is pre-chemotherapy, right one is post-chemotherapy. So we can see the medial component of the disease as well as the central component responding very well. You can see around 70 to 80% of the disease responding to the treatment. Only on the lateral aspect along the pleural deposit, we can see a disease, oligoprogression kind of thing, disease extending to the right chest wall. Next slide. So I'll start with Sika ma'am. Sika ma'am, how often do you see such responses? Like almost all the tumor responding, but only one part of it progressing, like oligoprogression?
Yeah, in advanced stage, it is usually in the literature. It's about 10 to 20% we see a mixed response. That is because the tumor itself is a heterogeneous tumor. So because the volume is very big, so in an advanced stage it will be much more of mixed response than a CR. So we would call it as a partial response or a stable disease, isn't it?
Definitely, totally agree with you, ma'am. And madam, what is how important is clinical responses in these kind of patients?
Actually, basically, when we have locally advanced, it is the patient has a lot of symptoms. So palliation symptoms is also very important for a quality of life. Whether we can give a cure, if there is a complete clinical response, obviously the patient will be much more, have a better quality of life than with a disease, like with a higher load of disease.
Definitely. So clinical response is again very important, especially
Very
in
important,
these kind of
yes.
patients where we can see the response is there. If there is clinical response as well, then mostly we'll take it towards partial response or stable disease. But if there is clinical progression, we take it towards oligoprogression. Next question. Madam, what is your take on oligoprogression patients, especially those with EGFR and AL positive patient, advanced lung cancer, those who are on targeted therapy, they are having oligoprogression in the form of, let's say, solitary or two liver metastasis or bone metastasis. What is the role of radiation in those patients?
So, yeah, in oligometastasis, we all know with the COMET trial. So if it is less than 5 metastasis, we can always target them with SBRT, and that is a curative treatment, not a palliative treatment. So we have seen there is a prolongation of life and also an improved quality of life.
Definitely. So it's very important to utilize the maximum benefit of these targeted therapy because they provide good response as well as a good quality of life to the patients. Next question. So I'll come to Dr. Parag. Dr. Parag, how will you proceed in this patient? This patient, we are talking about clinical response. This patient had chest pain. After 6 cycles with such good radiological response with oligoprogression, the pain also increased a lot. The patient was having tremendous pain. We know how intense pleuritic pains are. So this patient had clinical progression as well with good symptoms. So how would you proceed in this patient?
So if it is radiological progression and also patient is clinically progressing, then we should definitely choose the lateral line of treatment. We should, and for this reason, I need a biopsy from the progression site, whether there is same histopathological diagnosis or there is any change of it or any kind of we are missing or not, or look into that.
Definitely, biopsy from progressive components is very important. Next slide. So what I did was I started pembrolizumab with taxane. The reason why I did chemotherapy was because of intense pain in this patient. So again, 2 cycles of pembrolizumab with taxane was given. Next slide. And after this was the condition of the patient. The tumor was straight away coming out of the chest wall. The patient again was in tremendous pain. Next slide. So I'll come to Dr. Satya now. So how would you progress? How would we proceed in this case now?
So like Dr. Parag said, I'd like to go for a rebiopsy and would like to retest for the mutations, especially since the last time it was done with a PCR and ISC, I am assuming. This time I would like to go for a comprehensive NGS. If feasible financially, then both solid as well as liquid.
Definitely. So next question. So we all agree that NGS is a must in lung cancer, especially minimum 12 marker. NGS is must, both solid as well as liquid. Not only liquid, by NGS increases the chances of getting these targetable mutations. It also addresses the tumor heterogeneity, which again is very important. Next question. We were talking about co-mutations in the previous case as well. So I'll come to Dr. Ritika now. How, apart from these targetable mutations, any other co-mutations we specifically look for in these lung cancer patients? Dr. Ritika? Okay, so our medical oncologists can also take this question. Dr. Parag?
Basically, some aggressive variant of mutation like TP53, like or retinoblastoma, like these are all aggressive, or like small cell variant, or any other maybe resistant mechanism pathway like MATE or HER2. We can.
So basically, these are common mutations post EGFR TKI. So again, co-mutation, especially very well pointed out, TP53 is again one of the very common co-mutation associated with poor prognosis. Apart from that, we also had a wonderful discussion from Aparna madam. KRAS mutation with STK11 and KEAP1 is again very important. We're having a Triton 3B phase 3 trial going on, in which the KRAS with either KEAP1 or STK mutation, if it is present, mostly they respond better to IO doublet or with chemotherapy. Definitely IO doublet with chemotherapy, or chemotherapy with immunotherapy and target therapy like ABCP. Next slide. Next slide. So this is exactly what we did. We got a biopsy done from the progressing lesion, which again came out to be adenocarcinoma. Next slide. And 2 cycles of ABCP was started in this patient. Next slide. So you can see this. After 1 cycle of ABCP, there was clinical response. The tumor also regressed, and also there was decrease in the pain. And after another cycle of ABCP, the response was even further. Next slide. And this is what we got. The NGS was done, which showed EGFR exon 19 deletion with a VAF of 66%, TP53 co-mutation with a VAF of 86%. So I would come to again Sikha madam. Madam, how often do you see, or have you seen such patient where EGFR by PCR is negative, and we have done NGS again negative, it becomes positive?
I mean, I cannot give an experience because I'm a radiation oncologist, but when they come for SBRT, like this patient, I would have loved to have treated with SBRT because it's a very localized. Yes, I have seen few patients who have changed because as I said earlier also, a tumor is a heterogeneous. So the tissue which was taken earlier may not have been positive, but later on, when we have a lesser volume of the disease, and maybe this becomes positive.
And Dr. Satya, how important is TP53 mutation in particular in this patient?
Sorry, Dr. Ashish, could you please repeat the question?
How important is this TP53 co-mutation with a VAF of 86% in this patient?
Yeah. So I think it is very important because we know that we have the recent data. We have earlier had the data from Flora 2 as well as the recent data from the top 2 that these are very aggressive tumors, and we need to add chemotherapy with the targeted therapy to circumvent this mutations.
So the chemo backbone which we used to use was pemetrexed carboplatin with osimertinib, and this patient already had, we can say, clinical progression. Would you still add pemetrexed carboplatin in this patient?
I forgot. Initially, was there a response? So basically, why I'm asking is that because for me, if there is a 6 months DFI, then I would like to re-challenge. If it is not there, then I would like to partner with a different chemotherapy, a taxanes or a gemcitabine.
Definitely, totally agree. Next slide. So basically, next. So again, a very important question. I'll again come to Dr. Parag. How important is EGFR testing methods and labs?
Generally, I prefer NGS method. It is a broad spectrum, and we already discussed that we need both liquid biopsy and tissue biopsy, because as tumor is heterogeneous, so we can miss a part of that. There is a chance of false negative report in the tissue biopsy also, and that can be further we can detect on liquid biopsy.
Definitely. Dr. Satya, your take going for single test like PCR, FIS, or broad like NGS panel?
So I think there are pros and cons for both. For the PCR-based testing, if you're using the companion diagnostic, the COBAS one, it has a chance to miss the rarer EGFR mutations. Then earlier, there was a time when we used to test it with an ISCs. So that is, again, can cross-react with HER2 antibodies that can give some false positive results. But for my preference is the comprehensive NGS panel. Or if you want to, sometimes we can go for a digital droplet PCR if you want to measure for if you want to track any particular resistance mechanism, like if there is a clone and you want to track it. So false negativity is usually, I think, is very high in liquid biopsies because of the low shedding. In some tumors it can be as high as 32, 34, 40%, but false positivity is usually very less in liquid biopsies.
So basically you go for NGS
Yes,
comprehensive.
NGS.
So the message loud and clear, go for NGS minimum 12 marker, because even if we don't have the target therapy, we can enroll those patients under trial. We have ESCO data for that also. Minimum 12 marker panel has OS advantage over less than 12 marker panel. And again, Dr. Para, how important is overall response rate in this patient?
So the clinical response is dependent on that. So how patient is responding, and the patient is already on multiple line of chemotherapy or immunotherapy, and the disease burden also we can get an around on this.
Next slide. Next slide, we've already discussed this. So exactly what I did was I also started FLORA 2 osimertinib with pemetrexed carboplatin. The reason being, one, TP53, we have to give chemotherapy in addition to osimertinib. And we also have seen that this pemetrexed carboplatin had good response. There was mixed response. So maybe the addition of osimertinib to this chemotherapy backbone will take care of that progressive component. And that's exactly what happened. Next slide. After 4 cycles, this was the condition of the patient. Next slide. And then patient continued pemetrexed plus osimertinib for around 15 months. So there was a PFS of around 15 months. Next slide. In between, 2 PET scan was done. First in March, you can see March 25 PET scan, very good response. Next slide. Only loculated pleural effusion was present, which was drained. Next slide. Again in November, same loculated pleural effusion was present. Next slide. Next slide. You can see the wonderful response in this patient in November 2025. Next slide. So this was the condition of the patient in around November 2025. Next slide. So as we all know, the data IM Power 150 phase 3 study for advanced non-squamous lung cancer, randomized into 3 arms, ACP followed by atezolizumab maintenance versus ABCP followed by AB maintenance versus BCP followed by bevacizumab maintenance. Next slide. What was important in this trial, you can see around 10% of the patient also had EGFR positive. So next slide. And if you talk about the outcome of these EGFR positive patients, you can see there was PFS advantage of ABC arm compared to BCP arm. Next slide. We can see the separation in OS curve as well for this ABC versus BCP or ACP arm. So maybe this combination of atezolizumab and bevacizumab is doing something in this EGFR positive patient. Next slide. And we talked about overall response, especially was very important in this particular patients. The ORR with IM Power we have seen is 71% compared to 42%. So ORR with other chemoimmunotherapy trials has been around 50 to 60%. Next slide. And we also have data of bevacizumab in EGFR positive patients. We know the addition of bevacizumab to erlotinib didn't improve the outcome. Next slide. So this was the condition of the patient. Next slide. So, but in February 2026, 2 months back, the patient again came up with this. Next slide. Now, Dr. Satya, what's your take on the role of biopsy in this patient?
See, theoretically, if you ask me, we should again test for it. We should test if there is a on-target resistance mutation, or if there is a bilateral, if there is a parallel signaling pathways that has been activated. But practically, I don't think so. We repeatedly do rebiopsies and rebiopsies in our patients, especially once the patient progresses a lot. Sometimes patients are not very willing. But given a chance, if patient agrees, then I would again like to send for a rebiopsy and NGS.
Definitely, totally agree. And Dr. Parag, what is the role of NGS? What specifically do we look in NGS? in these patients?
I think we have this patient already had an NGS before, so I will not be able to repeat NGS currently with this patient, and maybe
Will you not repeat NGS post osimertinib progression if the patient progresses with a good PFS? The
post
patient is willing?
So patient is on osimertinib, then we can look for any other targetable mutation like mate, like pathway, or and there comes the role of repeat biopsy also. If there is small cell transformation, though the percentage is very much rare, and that's it.
Definitely. So up to 10% of the patient can have small cell transformation as well. And in NGS, we can even predict that loss of RB1 mutation can also be a predictor. Apart from that, MET amplification, HER2 amplification, post osimertinib, we know we have C797S mutation, and the trans variant of that can be rechallenged with the combination of first and third generation TKI. So again, the role of NGS is definitely there. And Dr. Satya, how often do you re-challenge platinum in advanced non-small cell lung cancer? Or if at all, do you re-challenge platinum in advanced non-small cell lung cancer?
Yeah, so like I said, if there is a control, first line, if there is a controlled disease and there is a good DFI, then I would like to re-challenge platinum.
Definitely, totally. And there are data also which says that in advanced condition in adenocarcinoma patient, if the PFS is 10 months or more, you can very well re-challenge platinum. So that's exactly what I did. Next slide. The patient was given amivantamab with pemetrexed and carboplatin who started in only 2 cycles. The patient had received till date now. Next slide. And next slide. And these are the weekly scans of the weekly pictures of the tumor condition which the patient sent to me. Next, this is week 0, week 1, week 2. Next slide. Week 3, 4, 5, and week 6. So again, after 2 cycles, the patient again showed a very good response. There was decrease in the pain as well, and the patient is now doing quite well. Next slide. So the take-home message is choose your labs and testing methods wisely. Mixed response, they are previous slide. They are not same as progressive disease. Biopsy NGS from progressive lesion can lead to increase in survival, and platinum re-challenge can lead to improved outcome in platinum-sensitive patient. Thank you. So I'll thank all my panelists and once again IAIO and the organization for the invitation. Thank you.
Thank you, Dr. Pathya.
Thank you, sir. Thank you for that insightful discussion. We now coming to our final talk of the evening. It's my pleasure to invite Dr. Venkatesh Chaudhary, Assistant Professor and Medical Oncologist, Homi Bhabha Cancer Hospital and Research Center, Visakhapatnam. Sir, the floor is yours.
Yeah. So good evening, one and all. Am I audible?
Yes, audible.
Should I share the screen or will it be shared by you? Shall I share? Is the screen visible?
Yes, sir, visible.
Yeah. So yeah. Good evening, one and all, and I thank IAIO team for providing this opportunity. So the topic given to me is the what is the current future of an advanced NSCLC, predominantly focusing on KRAS inhibitors and ADCs and any other emerging targets which we could have probably. And this is most evolving science, and the lung we do see every week or once in a while frequently we are getting new molecules coming and new molecules being tested. So in brief, we'll be discussing few things about this. And this is the same 22 actionable genomic sequence. There EGFR is predominant about 30%, 25 to 30%, then followed by ROS RET being 1 to 2%, HER2 mutations being 1 to 4%, and all fusions being 3 to 7%, and MET overexpressions about 15 to 50%, and amplifications being 1 to 5%, and KRAS mutations of areas G12V, D, and C being 15 to 20% in common. So this is a brief, and in addition also we do have some other rare mutations, agnostic mutations, NTRK, etc. And TROP2 overexpression, it bridges the histologies where 65% in adenocarcinoma and 75% we see in squamous cell histologies. So this is one more ADC molecules which we are seeing in the recent science. So my outline of the description. First, I'll tell brief a few about EGFR, 2 slides about ALK and ROS. Then I'll go for the ADCs and KRAS inhibitors in common. So this is the, we know the old gold standard. Osimertinib used to be the standard care, but now FLORA2 data has come, and also Mariposa data, where FLORA2 is osimertinib with chemotherapy with a PFS of 25 months, and Brain Met's PFS also being around 25 months. And Mariposa is amivantamab with the lazertinib. Lazertinib is soon we would get in India with a PFS 24 months and duration of response being about 25 months. But when to escalate from osimertinib monotherapy? As per the final conclusions of the articles and all, high CTD and co-occurring TP53 and RB1 mutations or CNS and liver mets, more consideration towards escalation for FLORA2 or doublet therapy or combination therapy is recommended. So post osimertinib first line usual most common, though there are guidelines says osimertinib, not many now setups are affordable, so many go for first line or second generation. Then if they're resistance osimertinib, then on osimertinib MET amplification where Mariposa 2 trial comes in, and if HER2 regulation or upregulation or exon 20 insertions, then Papillon study where amivantamab with chemotherapy with a PFS of 11.4 months. And there are emerging TKs like sunvozertinib, just Chinese molecules, and fumonitinib, which are few molecules with about 54% overall response rates. But these all are more or less phase 2 studies and all. And one slide about ALK fusions says ALK gold share about 3 to 7%, where the lorlatinib is the based on the Crown trial is presently the superior trial, where efficacy sustained even with EML ALK for variant 3 or TP53 co-mutations also in this study. And resistant target, now the 4th generation, which is NVL 655, which bypasses the TRK inhibition to target lorlatinib resistant. So G1202R is one of the most common lorlatinib resistance mutation, which we call compound mutations. So this 4th generation ALK inhibitor possibly could evade that. And ROS fusions about 1 to 2%. And these are the two molecules Trident based on the trials. Trident 1, which is repotrectinib, overall response rate of 80% with PFS 34 months in naive patient, and high potency against G2032R solvent form mutations. And also taltrectinib, which is overall response of 92% in naive patients and 54% in pre-treated patients. This is based on a Trust 1 and 2 trials. These are the trials. Now coming to antibody drug conjugates in a non-small cell, and where we are in the 2025 and 2026 era. So this is the brief spectrum where we see initial response, then once resistance is onset, there will be resistance where most of the drugs won't work, and we need the better drugs which overcomes these resistant mechanisms and all. And coming to ADC structure, we all know ADC is a specific monoclonal antibody targeting, where there will be a cytotoxic or immune stimulatory payload will be delivered, and finally reduced off-target toxicity compared to systemic chemotherapy. So these are the various biological effects or mechanisms involved in this ADCs. So ADCs offer a bypass to canonical TK resistance by delivering localized payloads regardless of intracellular kinase mutations. Also, they do have that bystander effect, which I'll be discussing. So this is a brief ADC where the structure with a payload missile, which binds an internalization, and there will be payload release and bystander effect. What exactly is this bystander effect is, in addition to the target molecules, the payload permeates the other structures which doesn't have the expressing antigen concern, and it also kills those cells which are cancer cells. So in addition to the expressing antigen, it also kills the neighbor cells which doesn't express these antigens, and by permeable and this payload delivery and all. So this is bystander effect through which this ADC acts. So coming to MET exon, so we have seen ALK and ROS and all. Now coming to MET exon 4 skipping and amplifications, where small molecules TKs like capmatinib and tepotinib, which were already discussed based on geometry trial and vision trial, and ADC is coming to this in MET amplification skipping. Telisotuzumab vedotin, which is based on a luminosity trial with which showed about 30% overall response rates and highly dependent on degree of IHC3 plus overexpression. So in MET overexpression states, this study as this molecule has shown some promising benefit. And coming to RET, which cell-to-TK, so far we know as selpercatinib based on Libretto trial and pralsetinib based on Arrow trial with the overall response of 72%. And the resistant pattern involved in this is G81X. So molecules are being developed in this for this resistant mutation patterns. Yeah. So this is the same that luminosity trial telisotuzumab vedotin in a previously treated non-squamous EGFR wild type NSCLC non-small cell, where IHC expression more than or equal to 50% showed a 34.6% overall response rates with a 5.5 months of PFS, and this led to accelerated FDA approval in May 2025. But the toxicity concerns for this drug are peripheral neuropathy, which has seen about 30% of the population in the study. And there are few studies which are emerging. There are few phase 2 studies in EGFR mutant disease. So earlier study which luminosity is a EGFR wild type, but there is a study telisotuzumab vedotin with erlotinib combination. We showed about 52.6% overall response rates in high c-MET and EGFR mutant disease, signaling a future role in TKI resistance. So this is one important. But this is phase 2 study which could probably be a future hypothesis generating to be. So that's about one part of ADC. Now coming to next part of ADC, TROP2 and HER3 based ADCs. So what is exactly the TROP2 biology? So earlier I already said TROP2, so highly expressed about 75% in squamous, but only 65% in adenocarcinoma. It's not a driver mutation, but a cell adhesion molecule which is correlated with poor prognosis. And this one drug, sacituzumab govitecan, which is based on EVOKE trial, showed OS improvement in immunotherapy refractory patients about 11.8 versus 8.3 months, despite missing the primary overall endpoint. But still in immunorefractory patients, it has done fairly well. And coming to HER3 biology, so where in EGFR TKI failure, where there will be HER3 upregulation, which is upregulated predominantly as a compensatory resistance mechanism in EGFR mutant NSCLC following TKI failure. So this is one drug based on HER3 lung 1 study, patritumab deruxtecan, where the payload is a topoisomerase 1 inhibitor, based on HER3 lung 1, which showed about 30% overall response rates and 5.5 months PFS, specifically in patients progressing on prior EGFR TKIs, with overall response rate of 35% and PFS of 5.5 months. So this is patritumab deruxtecan, HER3 deruxtecan. So there is one more TROP2 again, datopotamab deruxtecan. This is based on a TROPION lung 1 trial, where it is compared with datopotamab deruxtecan versus docetaxel. We showed a statistically significant PFS of 4.4 versus 3.7, but it showed to fail a OS benefit. But the one issue with this drug, or one how to monitor, or what shows this expression, or how to monitor, like IHC. Simple IHC is insufficient to say whether this drug is working well or not. But there is something called normalized membrane ratio score, which is a true predictive biomarker. So in those positive normalized membrane ratio scores, this drug did well with a PFS of 6.9 months compared to docetaxel, which is about 4.1 months. So what exactly is this NMR, normalized membrane ratio score, which is useful for this drug? So if you see standard IHC, it measures total TROP2 expression, which is unreliable predictor. But this normalized membrane ratio, it computes membrane localized versus total TROP2, and it is a better predictor of the drug molecule datopotamab deruxtecan response. So usually higher the response, like 0.75, what they have given. So this, what is the clinical significance of this score? NMR provides a quantitative and spatial analysis superior to traditional IHC for predicting this drug efficacy. So with this, based on TROPION lung 05, this is one more, earlier TROPION 01, this is TROPION lung 05. Based on this, for EGFR mutant population. So if you see TROPION lung 01, it is for overall. But here this 05 trial, it is for EGFR mutant population, where this drug has shown an overall response rates about 44%, and because of this, it got an accelerated FDA approval in June 2025. But here, NMR is one thing which needs to be calculated for drug efficacy to see. So TROP2 advancements, what we are seeing, and a non-squamous EGFR mutant, as we already seen, datopotamab deruxtecan, based on TROPION lung 05, which study, and squamous sacituzumab govitecan, based on EVOKE2 trial, where sacituzumab govitecan with pembrolizumab is given, showed a 73% overall response to squamous with high PDL1 more than 50%. And there is OptiTROP lung study, which is a combination, which showed 78% of overall response rates, more skewed towards squamous and PDL1 elevated conditions. So these are the various ADCs of note. TDX3 transformed deruxtecan, which we are using, which we do use. It's a topoisomerase inhibitor 1 is a payload with based on Destiny 01 and 02 lung trials and all. And patritumab deruxtecan, as I already discussed, HER3, which is a HER3 lung 01 trial. And here also payload is topoisomerase 1. And sacituzumab govitecan, TROP2, it has shown a benefit. Payload is SN38 and based on EVOKE-01 trial. And datopotamab deruxtecan, TROPION lung study, and also telisotuzumab vedotin, which I already discussed, and met based on the luminosity trial, which has shown a significant overall response rates. So these are the various ADCs with various targets and payloads. So yes, so the modality, earlier we to be on a small target TKS molecules. And now we have moved more towards ADCs, bispecifics, PROTACs. So what is this? PROTACs is proteasome targeting agents of chimeras, which are the new emerging drinks, which more or less ubiquinate coenzyme mechanisms and all will be hampered. So in a simple way. So these are the various things where you have moved generation, first generation to next generation TKS, and now to the bispecifics like amivantamab, and also to the ADCs. So the future of NSCLC lies in tracking the evolution of tumor, deploying highly selective small molecules against primary drivers, and overwhelming acquired resistant pathways with targeted macromolecular payloads. And early pan-HER2 also we have, where earlier used to be pan-HER2 TKS, where afatinib, dacometinib with the resulting overall response rate below 20%. Then we have moved to ADCs, where Destiny Lung, TDXD, and but with at the risk of side effects like interstitial lung diseases. Then we have moved to next generation TKS like zongertinib, which is highly selective, overall response rate of 72%. And also there are a few other molecules based on SOHO 1 trial and all, which are showing some responses with good overall response rates, which could be the future in further years. So this is same again the Destiny Lung 02, where they have seen the 2 doses have been compared, and finally 5.4 mg per kg is the safest dose with 49% overall response rates and 9.9 months of PFS, and ILD reduced it by 6% rather than higher doses. And mutation versus overexpression, if you see here, mutations have 55% overall response rates compared to IHC overexpression, which is about 25% only. And this is again HER3 trial, patritumab deruxtecan, which I already discussed. And these are the other emerging targets like ITGB6. This is a cell surface receptor where sigvotatug vedotin plus pembrolizumab, which has shown 57% overall response rates in PD-L1 positive patients. And few phase 3 studies are ongoing. And B7H3, which is associated with poor prognosis and immune evasion, where the molecules are being tried with a 40% overall response rate in squamous, and AXL and novel constructs where mecbotamab, vedotin, and HLX43, which are advancing to overcome the targeted therapy resistance. And HLX43 is a novel PD-L1 targeted ADC, and which is entering phase 2 studies. Yeah, so the biomarker, we have moved from TK era. What is the difference between ADC era? So TK is the intracellular kinase inhibition, while ADC is surface antigen binding and internalization, where biomarker genomic mutations, while ADC reliable complex multifactorial and highly universal predictive for TK era, interchangeable across drug classes, but ADC is variable and drug specific. But what are the inconsistencies? HER2 requires mutations, IHC fails, we have already seen as per the Destiny study also. c-MET requires high IHC expression, where in that luminosity study which I have shown, and HER3 response regardless of IHC, and TROP2 requires digital NMR computation, which is a digital one, unless the regular IHC doesn't show, IHC positive is not reliable, but a higher NMR computation, drug efficacy is good. So these are the few inconsistencies or issues with concern with the ADCs. And systemic challenges, toxicity and burden, though unique, which are unique for a few ADCs, where ILD, pneumonitis, which we do see very commonly, neuropathies, as already discussed with tislelizumab vedotin, and limits the poor performance status patients' usage. And evolving resistance, moving beyond canonical TK resistance mechanisms, including antigen shedding, down regulation, increased reflex pump activity, and impaired lysosomal processing. And diagnostic infrastructure like NMR assessment and all these are complex, and financial toxicity is a major concern in our setups. So these are the challenges with the ADCs we do see. Then next, coming to the last topic, KRAS inhibition. So KRAS mutations and what is our spec. So we know 30% of overall KRAS mutation rates in NSCLC, where G12C is common with 40%, followed by G12D, G12V which 21%, and G12D 17%, and remaining all in the small numbers. So what exactly is the KRAS activity? So we all know KRAS inhibitors. The first generation are off inhibitors, where they bound to GDP bound KRAS, and that next generation pan KRAS inhibitors and next generation on therapies which bound to actively continuously act to GTP state. So these are the new drugs which attack this GTP cycle, where GDP bound KRAS are off inhibitors, which are first generation targeted drugs, which we do have right now available. And the newer emerging are pan KRAS and target on therapies. They are on GTP bound, which are continuously active. So this is one thing which was discussed in earlier 2 panels. So co-mutations with, and already Dr. Aparna ma'am has highlighted. So co-mutations dictate the tumor microenvironment and determine immune checkpoint inhibitor susceptibility. So KRAS mutations are co-mutated with STK11 about 20 to 30%, KEAP1 25 to 30%, SMARCS A4, and TP53. And if you see immunotherapy resistant or STK keep, these are the cold tumors. And as we move towards immune susceptible TP53, which is about 40 to 50% are immunotherapy susceptible. While TP53 co-mutations create a favorable environment for immunotherapy, STK11 creates an immunosuppressive void. So that's why these cold microenvironment are usually co-mutations with KRAS are immunotherapy resistant usually. So same again, STK11, which is a cold tumor, which act highly resistant to standard immunotherapy. KEAP11 again interacts with STK11 to disrupt the redox hemostasis. SMARCA4, poor outcomes with limited targeted options. And TP53, which is a hot immune tumor microenvironment where T cell mobilization and high PD-L1 expression, which fares significantly better with immunotherapy. Yeah, these are the two first generation of inhibitors, which I already told GDP of inhibitors. So these are sotorasib, based on code break trial with overall response rates of 37%, median PFS about 5.6 to 6.8 months, displays benefit in treated stable brain mets. And adagrasib, which irreversibly bind to switch 2 pocket, it's based on the crystal trial with an overall response rate of 43% and median PFS of 6.5 months. And 33.3% intracranial overall response rates in patients with stable CNS metastasis. And this is same again. The third molecule is divarasib, which is a phase 1 molecule based on the Crescendo study, which showed about 53% overall response rates, but still the data is maturing. So these are the two first generation of therapy drugs. And same as a immunotherapy combination with chemotherapy for KRAS. Standard first line is pembro with chemotherapy, 9-month PFS regardless of KRAS mutation status. While ABCP study yielded about 19.8 months median OS for KRAS mutated patients. And cold tumor strategy. So we also STK11 keep, these all are cold tumors. So usually doesn't respond well to immunotherapy. So they have done few studies like Poseidon and Checkmate 227, double checkpoint therapy have been tried and which have shown some benefits. So these are the methods, these are the various ways to tackle the cold tumors and improving the outcomes. Double immunotherapy has been tried. So these are the next generation, what are the features of this, and there are various drugs being tried of inhibitors on GDP bound inactive, which are like olomorasib, which are like showing some benefits of all the drugs which are happening. So these are the following drugs which are showing some positive benefit like olomorasib and opnorasib, and on inhibitors like GTP active. So RMC 6291 and RMC 9805 is showing some promise. And PROTACs, as you already said, PROTACs are proteasome targeting agents, chimeras. So these are the drugs which are being in a pipeline in future. And G12C, olomorasib, which is off inhibitor, and divarasib is an off. Opnorasib and RMC629, these are the G12C inhibitors, which demonstrates higher selectivity and distinct clinical advantages. And the novel G12D and G12E also, there are various targeted therapies which are showing promises, like including PROTACs and all other therapies, on and off therapy targeted, which shows, which penetrates the colder nucleophile regions of G12D and G12E and improving the outcomes and overall response rates. And pan-KRAS inhibitors, which bypass variant-specific constraints by targeting active GTP bound universal state. So this is one RMC6236 molecule, which is a phase 1, still overall response of 38% and median OS of 17 months. And active clinical trial is going on, RMC Lung 0101. And looking forward, like pan-KRAS targeting opens potential for broad efficacy across multiple KRAS-driven cancers, potentially overcoming resistant mechanisms observed with G12C specific inhibitors, and future combination may further enhance durability. And so these are the various KRAS inhibitors, off therapies, on inhibitors, and pan-KRAS inhibitors for various KRAS mutations like G12C, G12E, D, and all. So of these, so far only approved are sotorasib and adagrasib, which are KRAS off inhibitors. And rest of the things are in loop line. So probably we might see in the next decade or so, these all molecules, at least half of them coming into success in phase 3 studies. So KRAS inhibition failure, primary resistance treatment, which occurs pre-treatment by co-mutations, and acquired resistance could be because on target could be secondary KRAS mutations, and off target could be gain of function in RTK regulators like RET, BRAF, EGFR, HER2, or loss of tumor suppressors. And these are the two various mechanisms of mutation, like bypass mechanism, where upstream regulator, downstream regulator things are reactivations will be happening, and also adeno to squamous transformation, which is heavily linked to STK11 or LKB1Q mutation, and also epithelial mesenchymal transformation. So the ultimate horizon of KRAS is pushing into early stages, resectable NSCLC trials, where Nautica-1, KSAB, SBRT, and to intercept KRAS before acquiring resistance is the future. Yeah, this is same diagnostics followed by upfront chemoline therapy, then ADCs or KRAS based on whatever is available. Yeah, thank you. And I.
Thank you,
Hello.
sir.
Yeah.
Thank you for that forward-looking presentation. I request participants to post their question in the chat box and I will direct them to the respective faculty. If any question will be there, please put in the chat box.
So in a driver mutant, there is a question called in a driver mutant TP53 co-mutation, is there any role of IO? No. There is no role of IO even if there is a TP53 mutation.
Any questions? So there is second more question. We now move on to the closing remarks. As we come to the end of this enriching session, I would like to sincerely thank our program director, Dr. Bala Stalin Chaudhary, all our esteemed faculty and panelists and participants. So all the participants will be receiving certificate 2 to 3 working days to your registered mail ID. Repeat. All the participants will be receiving certificate 2 to 3 working days to your registered mail ID. Thank you all once again for joining us. We hope to see you at the future IAIO academic initiatives. Have a wonderful evening. Thank you, everyone.
Thank you.
Thank you, sir.